Welcome to the Deep Dive.
It's great to be here.
We have a really fascinating mission today. We're exploring excerpts from a highly detailed medical text. It's called The Mechanics of Sinus Tachycardia and Arrhythmia. And we're basically going to unpack exactly what is happening in the internal wiring of your chest when this occurs.
And we're going to find out why an irregular heartbeat, something that feels so profoundly wrong in the moment, might actually be flawlessly normal. Yeah, because that sensation sends so many people rushing to their doctors in an absolute panic.
It really does. When patients seek medical attention with, an uncomfortable awareness of their heartbeat as their chief complaint, there is usually a deep-seated fear of serious underlying conditions.
Because the mind immediately goes to things with highly intimidating names.
Right, exactly. We're talking about supraventricular tachycardia, ventricular tachycardia, or various forms of atrial and ventricular ectopi. But the medical field has a very specific way of distinguishing those potentially serious conditions from something completely harmless.
And that's the ultimate detective tool, right? The 12-lead electrocardiogram, the ECG.
The ECG, yes. It's all about looking at the raw electrical data to find one very specific, crucial clue.
Which is the characteristic P wave.
The P wave is the absolute foundation of figuring out what's really going on. We need to really understand the anatomy of a normal heartbeat before we can understand why an irregular one might be okay.
So let's break down that precise electrical fingerprint.
A true characteristic sinus P wave has to originate from a very specific geographic location in the heart. It must arise from the superior and lateral aspect of the right atrium.
The top right.
Yes. The electrical signal has to start in that precise spot to trigger the coordinated squeeze that pushes blood through the body.
So the 12-lead ECG is basically a 3D wireframe map of the heart. It's tracking the direction of that electrical signal. If the signal starts at the superior and lateral part of the right atrium, it shoots down and to the left across the heart.
Exactly. The frontal plane axis is directed inferiorly and leftward.
Meaning the ECG is literally mapping the physical direction of the electricity on a grid.
Because the ECG utilizes 12 different leads, doctors are essentially looking through 12 different camera angles at that single electrical wave. And they have an exact checklist of visual markers they need to see to confirm the signal is moving exactly inferiorly and leftward. First, they look for a positive deflection in leads 1, 2, and 3, as well as lead AVF.
So if we think about those specific leads as cameras positioned on the lower left side of the body, the electrical wave is rushing directly toward them.
Right, it's approaching the sensor.
That's why the little wave on the graph paper points up. It's a positive deflection because the energy is coming right at it.
Then we look at lead AVR. This lead is looking from a completely different angle. It's positioned up near the right shoulder.
And because the electrical signal originates near the right shoulder and moves away toward the lower left,
that same P wave must be negative in AVR.
It points down because the wave is retreating from that specific camera angle.
You've got it. Finally, in lead V1, which is positioned right over the chest, the P wave has a very specific signature. It's an initially positive biphasic morphology.
Biphasic meaning two parts.
Yes. It goes up first as the wave sweeps over the right atrium toward the lead, and then dips down as it moves away to activate the left atrium. That creates a distinct two-part wave.
That really paints a clear picture of how rigorous this mathematical standard is. If the electrical signature on the ECG shows those positive deflections in I2, 3, and AVF, a negative wave in AVR, and that distinct, initially positive biphasic shape in V1, the doctor knows the exact origin of the heartbeat.
The exact origin. And if you combine that perfect electrical profile with a rate that sits comfortably between 60 and 100 beats per minute,
you are in normal sinus rhythm.
Exactly. The heart's wiring is operating exactly to factory specifications.
Okay, so that's the baseline. But if the origin of the heartbeat is perfectly normal, coming right from that sinus node and matching all those ECG criteria, what happens when the timing gets thrown off?
That introduces the main concept we're talking about today, sinus arrhythmia.
The word arrhythmia implies something is broken or failing.
It does, but in this case, the definition relies on an incredibly small, specific unit of measurement. It is a rhythm that arises from the normal sinus node origin, so the P wave looks perfect, but there's an irregularity between the PP intervals that is strictly greater than 120 milliseconds.
Just 120 milliseconds. That's slightly more than 1/10 of a second of variation between beats.
It's a tiny fraction of time.
Yet the body can feel that irregularity,
Mm.
and it shows up bright as day on the ECG readout.
It absolutely does. And the 120 millisecond threshold is crucial for the differential diagnosis. A doctor looking at that ECG has to be certain of what they're seeing.
Right.
If a patient has an irregular rhythm, but the doctor notices that the P waves look different from each other on the readout, meaning they have varying morphologies, then it's absolutely not sinus arrhythmia.
Because if the shapes are different, the origin of the electrical signal is jumping around. It isn't coming from that single perfect spot in the right atrium anymore.
Precisely. If there are different P wave morphologies, the arrhythmia is most likely due to premature atrial contractions.
Oh, why?
Yes, PACEs. The absolute key to diagnosing sinus arrhythmia is that uniform, perfect shape of the P wave. The signal is healthy. It's just arriving on a slightly delayed or accelerated schedule.
Why does this happen when you're just sitting around? You'd think the heart gets out of rhythm when it's stressed or when you're running a marathon.
It's a fascinating paradox. Sinus arrhythmia usually occurs completely at rest.
And the text explains the why behind this. It comes down to vagal tone.
Yes. The vagus nerve is a major component of your autonomic nervous system. It heavily influences your resting state. When you're sitting on the couch, relaxed, your vagal tone is high.
It acts as a natural dampener on the pacemaker of your heart, keeping the rate slow and steady.
But that dampening isn't a perfectly flat, static mechanism. It has inherent microscopic fluctuation.
I like thinking about vagal tone like the brake pedal of the nervous system. That really helps visualize this. When you're at rest, your foot is resting firmly on the brake pedal and the heart is idling.
And it's a slightly uneven idle.
Right. But sinus arrhythmia is often completely eliminated with the higher heart rates observed during exertion. When you stand up and go for a run, you're taking your foot off that brake pedal.
When you exert yourself, your sympathetic nervous system takes over. The removal of vagal tone allows the heart rate to increase smoothly and consistently.
Because that dampening, fluctuating influence of the vagus nerve is gone.
Exactly. The irregularity of the sinus arrhythmia vanishes completely. The heart pumps rapidly and uniformly to meet the oxygen demands of the body.
So the irregularity isn't a sign of weakness. It's actually a sign of the delicate, complex control the resting nervous system has over the heart.
It really is.
Which brings us to the three distinct categories or flavors of sinus arrhythmia from the text. Understanding these three types reveals how interconnected our bodily systems truly are. The first one is type 1, respirophasic sinus arrhythmia.
As the name suggests, this type is tied directly to breathing. That vagal tone we just discussed fluctuates in perfect rhythm with the respiratory cycle.
So during inspiration, when you breathe in, vagal tone is reflexively inhibited.
The brake pedal lifts up just a little bit while you inhale.
And because the brake is lifted, the heart rate naturally speeds up a bit.
Then during expiration, when you breathe out, the vagal tone is restored, the brake is reapplied, and the heart slows back down.
It's a continuous wave-like speeding up and slowing down of the heartbeat that perfectly mirrors the rise and fall of the chest.
Yes.
For you listening right now, if you sit quietly, feel your pulse, and take a long, slow, deep breath in, you might actually feel the beats get closer together. As you slowly exhale, you'll feel them space out. That is respirophasic sinus arrhythmia in action.
And there's an extreme version of this as well. The text emphasizes that breath holding can lead to deeply exaggerated pauses in the heartbeat.
Wow.
We see this extreme version frequently in a clinical setting with patients who have obstructive sleep apnea.
When they stop breathing momentarily during the night.
Exactly. It triggers a profound shift in that vagal tone, leading to massive, exaggerated pauses between heartbeats on their ECG. It underscores just how powerfully the lungs and the heart are linked through the brainstem.
So that covers the first flavor, driven by the breath. The second flavor is much more complex. Type 2 is ventriculophasic sinus arrhythmia.
We're moving away from the lungs now and looking strictly at the internal plumbing and pressure mechanics of the heart itself.
This is most often observed with heart block or after a premature ventricular contraction, a PVC.
The underlying logic here is fascinating. In ventriculophasic sinus arrhythmia, the irregularity isn't tied to breathing. It's tied to an interposed ventricular complex.
The PP interval, which is the time between the normal signals from the top of the heart, actually shortens when a ventricular beat occurs between them.
Right. An extra beat happens at the bottom of the heart, in the ventricles, and that somehow causes the next normal signal from the top to fire a little bit earlier than scheduled.
Because the cardiovascular system is a closed loop of pressure and fluid dynamics, which explains why the top of the heart reacts to what the bottom is doing.
The prevailing physiological theory for this relies on the baroreceptor reflex. Baroreceptors are microscopic stretch receptors. They are essentially pressure sensors lining major blood vessels like the aortic arch and the carotid arteries.
Those sensors are constantly measuring the stretch of the blood vessel walls to monitor blood pressure in real time.
When there's a premature ventricular contraction or pause from a heart block, there's a longer ventricular filling time.
Because the heart waited an extra fraction of a second before the next effective beat.
Exactly. So the ventricle filled up with significantly more blood than usual. When that subsequent beat finally happens, it pushes out a massive volume of blood, a vastly increased stroke volume.
That massive surge of blood blasts out of the heart and hits the aortic arch. The baroreceptors get stretched out dramatically.
And they immediately sense this huge wave of pressure and send an urgent alarm signal directly back to the brainstem.
It is amazing how the body regulates itself.
It really is. The response to that sudden spike in pressure from the increased stroke volume is a reflex adjustment that ultimately affects the timing of the very next sinus node firing. The nervous system intentionally shortens that PP interval.
It's an exquisite, instantaneous feedback loop between fluid volume, pressure sensors, and the electrical pacemaker of the heart.
The body is prioritizing pressure stability over rhythmic timing.
And all of that complex physics and biology happens in a fraction of a second, completely outside of conscious awareness, just to keep the internal pressure balanced. That's ventriculophasic.
Which leaves us with the final category, type 3, nonphasic sinus arrhythmia.
The wild card of the bunch.
Nonphasic sinus arrhythmia is defined by what it's not. It refers to variations in the sinus P intervals that are completely unrelated to the respiratory cycle and entirely unrelated to the cardiac cycle we just described with the stroke volumes and baroreceptors.
It doesn't match your breathing, and it isn't caused by a pressure feedback loop from an extra beat.
Right. The intervals between the heartbeats vary by more than that 120 millisecond threshold. But there's no obvious external trigger or internal cyclical pattern driving it. It just happens on its own.
After unpacking all this diagnostic detective work, we need to get to the ultimate synthesis, the bottom line from the medical text.
What does all of this mean for the patient experiencing it?
Right.
The medical conclusion is unambiguous. Regardless of the mechanism, whether the sinus arrhythmia is respiratophasic, ventriculophasic, or nonphasic, if the patient is asymptomatic, it does not warrant any further cardiac evaluation.
That is the ultimate so what. If they aren't passing out or having severe chest pain, but rather just experiencing that harmless fluttering or irregularity, no further investigation is needed.
Asymptomatic sinus arrhythmia is not considered pathogenic. It isn't a disease state, and it isn't a sign of a failing pump or bad electrical wiring. It's simply a feature of healthy human physiology.
Reassuring patients of this fact has got to be a massive part of cardiovascular care.
Oh, absolutely. Instead of seeing the irregularity as a flaw or a warning sign of impending doom, we can recognize it as evidence of an incredibly sophisticated, responsive system operating exactly as it was designed to. We've explored the elastic nature of a resting rhythm, but what are the exact physiological mechanics when the heart is required to cross that threshold of 100 beats per minute?
This is where we get into tachycardia.
Here's where it gets really interesting. Let's look at the mechanics of physiologic sinus tachycardia. The engine is revving up. But what blew my mind in the data is that the command center doesn't just sit in the exact same microscopic spot and fire faster.
No, it doesn't.
There is a literal spatial shift in the origin of the electricity.
Yes, the focus of earliest activation actually migrates. The sinus node isn't just a single point. It's a relatively large distributed complex of cells along that crista terminalis.
Right.
When the body experiences a surge of sympathetic stimulation, such as the release of catecholamines like epinephrine, or a significant withdrawal of parasympathetic vagal tone, the hierarchy of those pacemaker cells changes.
The source states that the focus of earliest activation typically shifts more leftward and closer to the superior septal aspect of the crista terminalis.
The dominant firing point physically moves higher and closer to the septum.
And because the origin point of the electrical wave has spatially shifted, the three-dimensional vector of the wave shifts slightly as well.
Exactly. This subtle migration alters the ECG footprint. The data explicitly notes that this leftward superior septal shift in the pacemaker's origin produces taller P waves in the inferior limb leads. Let's break down why that happens. The inferior limb leads on an ECG, specifically leads 2, 3, and AVF, are essentially cameras looking up at the heart from the bottom. When the pacemaker focus shifts superiorly along that crista terminalis, the electrical wave of the atrium depolarizing heads more directly, straight down toward those cameras.
And in electrophysiology, electricity moving directly toward a lead creates a taller, more positive deflection, hence the taller P wave.
Exactly. A physician looking at a trace isn't just measuring the millimeter distance between QRS complexes to calculate the rate. They're looking at the amplitude of the P wave in those specific inferior leads to verify that the physical origin of the beat has made that expected anatomical shift.
It proves the acceleration is originating from the correct autonomic response. But this brings us to a massive challenge in clinical detective work. Doctors have to differentiate between a healthy, appropriate speed up, this physiologic sinus tachycardia, and a pathological rhythm, like a focal atrial tachycardia.
Right, a rhythm that just happens to originate from tissue right next to the sinus node.
That is a profound diagnostic hurdle. Because if a rogue cluster of cells situated mere millimeters away from the sinus node begins firing autonomously at 150 beats per minute, the electrical vector it produces will look virtually identical to a physiologic sinus tachycardia firing at 150 beats per minute.
The spatial origin is so close that the 12-lead ECG cameras can barely discern a difference in the footprint.
If the footprints look the same, how do you determine if the heart is racing because it's appropriately responding to a physiological demand, or if it's racing because of an isolated electrical short circuit?
The primary diagnostic clue lies entirely in the behavioral profile of the rhythm, specifically the onset and the offset.
Okay.
Physiologic sinus tachycardia is governed by systemic autonomic tone, which ramped up and down smoothly. Therefore, it exhibits a gradual rate increase and a gradual rate decrease. It mirrors the underlying physiological demand.
So if you go for a run, your heart rate climbs smoothly from 70 to 140 over several minutes, and when you stop, it smoothly glides back down.
Precisely. Focal atrial tachycardia, conversely, is an electrical event. It typically exhibits an abrupt instantaneous onset and offset.
Like a light switch.
Yes. The rhythm jumps from 70 to 150 beats per minute in a single heartbeat and terminates just as suddenly.
However, even with that behavioral distinction, the data concedes that differentiation can be remarkably difficult.
Very difficult.
In complex cases, it may require extended telemetry monitoring to catch the exact moment of initiation.
You have to see how it starts.
Right, or even an invasive electrophysiology study where catheters are placed directly inside the heart to map the exact millimeter of tissue generating the rhythm.
Sometimes that's the only way to know for sure.
Assuming the detective work points to a gradual physiologic sinus tachycardia, the clinical focus has to immediately shift away from the heart itself, because as the data outlines, a physiologic tachycardia is rarely a primary cardiac problem.
It is almost always an appropriate secondary response to a systemic stressor. The heart is merely the alarm bell.
The sinus node is simply acting as a highly sensitive gauge of the body's metabolic or neurochemical environment.
Exactly. The responsibility of the physician is to identify what is driving that demand.
Let's look at the sheer diversity of triggers that appropriately force the sinus node to accelerate. They start with the purely physiologic causes.
Yeah, the normal functions of living.
Emotion, physical exercise, sexual intercourse, pain, and pregnancy. The increased metabolic demands of these states dictate a higher cardiac output.
But the clinical complexity deepens when we examine the pathologic causes. These are underlying medical conditions that force the heart into a compensatory overdrive.
And the text emphasizes a critical principle of internal medicine. You must identify and treat these underlying, often reversible causes before ever assuming the tachycardia is a primary rhythm disorder.
You can't just slow the heart down if it's beating fast for a reason. Transitioning to the pathological causes, the medical table is incredibly dense. We need to group these by their systemic mechanisms for you to really make sense of it.
Let's start with systemic and environmental stresses. Things like fever, dehydration, anemia, and infection.
The hemodynamics behind these are really revealing. Take dehydration, for example. As you lose fluid, your intravascular blood volume drops.
Which decreases venous return to the heart.
Right. And that means a lower stroke volume, which is the amount of blood pushed out with each beat. So to maintain the necessary overall cardiac output, the only variable the body can change is the heart rate. It is a compensatory tachycardia.
Anemia operates on a similar principle of compensation, but rather than a lack of fluid volume, it's a lack of oxygen carrying capacity.
Because with fewer red blood cells, the heart just has to circulate the blood faster to deliver the same required amount of oxygen to the tissues.
Then we have the psychological category, which primarily lists anxiety and panic attacks.
Moving into the endocrine triggers, we're looking at diseases that hijack the body's hormonal messengers. The table lists hyperthyroidism, hypoglycemia, pheochromocytoma, Cushing's disease, and diabetes mellitus.
Hyperthyroidism is a classic driver. The thyroid gland dictates the body's basal metabolic rate. When it overproduces thyroid hormone, it upregulates beta-adrenergic receptors across the cardiovascular system.
It literally makes the heart more sensitive to the sympathetic nervous system.
And pheochromocytoma is an even more extreme example. It is a rare catecholamine-secreting tumor usually found in the adrenal glands.
It operates like a broken faucet. It just indiscriminately dumps massive surges of epinephrine and norepinephrine directly into the bloodstream. It's slamming on the SA node's gas pedal.
And we must highlight a very specific caveat the clinical table includes regarding diabetes mellitus. It lists diabetes specifically with evidence of autonomic dysfunction.
That's a crucial distinction. Chronic high blood sugar can damage the vagus nerve.
Yeah.
And remember, that's the very nerve responsible for that parasympathetic braking system we discussed earlier.
So when the vagus nerve suffers neuropathy, the sympathetic nervous system is left essentially unopposed.
It's incredible how many different systemic failures funnel into this one cardiac response. The table also outlines severe cardiovascular and pulmonary events: pulmonary embolus, myocardial infarction, pericarditis, valve disease, decompensated heart failure, and shock.
In these acute scenarios, tachycardia is the heart fighting a losing battle against structural failure or profound obstructive shock.
Right. Whether it's the pumping mechanism failing during a myocardial infarction or the structural integrity of a valve giving way, the drop in forward perfusion triggers massive baroreceptor reflexes.
The body senses the drop in blood pressure and demands the heart speed up to save the vital organs.
Exactly. The table also briefly touches on a few other pathologic causes like malignancies and alcohol withdrawal.
Here's where it gets really interesting. We've mapped out the natural physiological responses and the pathological disease states, but the table dedicates a massive section to exogenous chemicals, the substances we deliberately put into our bodies.
The drugs category really blurs the line between everyday habits and heavy pharmacological intervention.
It fundamentally reframes how we should view common substances. The table prominently lists caffeine and alcohol. We culturally treat caffeine as a harmless morning ritual, but pharmacologically, it is a phosphodiesterase inhibitor.
It prevents the breakdown of cyclic AMP inside the cells, essentially prolonging the sympathetic stimulatory effect on the SA node.
The table also lists beta blocker withdrawal. If a patient is on beta blockers, the medication is actively shielding those cardiac receptors from adrenaline.
And the body responds to this blockade by upregulating. It creates more receptors to try and catch whatever adrenaline is actually available.
So if you abruptly stop the medication, you suddenly expose an abnormally high number of receptors to the body's natural catecholamines, resulting in a violent spike in heart rate.
Which is exactly why weaning off cardiovascular medication requires such precise clinical management. The medical side of the table also lists critical care drugs: epinephrine, norepinephrine, dopamine, dobutamine, and atropine.
These are agents designed to artificially manipulate the exact autonomic levers we've been discussing. Atropine, for example, is a direct anticholinergic.
Right, it blocks the vagus nerve, immediately cutting the parasympathetic brake.
The source also highlights beta-2 adrenergic receptor agonists, specifically citing salbutamol, which is widely used in asthma inhalers.
The mechanism there is a matter of receptor crossover and systemic response. Salbutamol targets the beta-2 receptors in the lungs to bronchodilate the airways.
But beta-2 receptors also exist in the heart and the peripheral vasculature.
Exactly. The peripheral vasodilation drops blood pressure slightly, which triggers a reflex tachycardia. Plus, the direct stimulation of the cardiac beta-2 receptors further drives the rate up.
The pharmacological list even extends to chemotherapy agents like doxorubicin and daunorubicin, proving that profound cellular toxicity anywhere in the body manifests as cardiac stress.
But we have to look at the final category in the medical table: illicit drugs. The sources list amphetamines, lysergic acid, diethylamide, LSD, psilocybin, ecstasy, and cocaine.
These compounds trigger massive unphysiological releases of neurotransmitters or inhibit their reuptake, functionally flooding the sinus node with accelerator signals.
The sheer volume of these triggers underscores a vital clinical philosophy. The heart rate is a downstream indicator. The text lays out a non-negotiable clinical rule. The physician must aggressively rule out structural and functional cardiovascular abnormalities before assuming the tachycardia is non-physiologic or benign.
The clinical data specifically singles out pulmonary embolism. The protocol also demands investigating highly reversible hidden causes, checking thyroid panels to rule out hyperthyroidism, and running complete blood counts to rule out hidden anemia.
You cannot treat the heart rate until you rule out the systemic failure driving it.
So what does this all mean for the actual treatment strategy? We have a condition that is a symptom of dozens of other problems.
The clinical philosophy is one of profound restraint. The text explicitly dictates that treatment is aimed exclusively at the underlying condition, not at the sinus node itself.
You don't put a governor on the engine if the house is on fire. You put out the fire.
Exactly. You hydrate the dehydrated patient, you surgically remove the pheochromocytoma, you treat the infection.
Attempting to artificially slow down a physiologic sinus tachycardia with a beta blocker, when the body is desperately trying to compensate for anemia or a pulmonary embolism, would actively crash the patient's hemodynamics.
You would be removing their only compensatory survival mechanism.
The text concludes with a highly reassuring baseline standard. A relatively elevated sinus rate, even at rest without any identifiable underlying cause, and particularly without symptoms, typically does not warrant any pharmacological treatment. But that brings us to the agonizing inverse of that scenario. What happens when there is no underlying pathology? There's no infection, no acute stressor, no dehydration, but the patient is experiencing severe debilitating symptoms.
This is a tough area. And that is where this algorithm takes us into much murkier waters.
Yeah. If it's not a reversible cause, we have to evaluate for a spectrum of syndromes resulting in inappropriate sinus tachycardia. That brings us to our first major syndrome on the flowchart, POTS. That stands for Postural Orthostatic Tachycardia Syndrome. And this isn't just feeling a little lightheaded if you jump out of bed too fast.
Not at all.
The clinical criteria are incredibly strict. To be diagnosed with POTS, a patient has to have a symptomatic sinus tachycardia that is directly triggered by that postural change.
Specifically going from a supine position lying totally flat to standing up.
Exactly. And within 10 minutes of standing, the patient's heart rate has to shoot up by at least 30 beats per minute, or it has to exceed 120 beats per minute entirely.
And crucially, this is so important, this happens without a drop in blood pressure.
Without a drop. Why is that specific detail so important?
That absence of a blood pressure drop is the vital clue. It tells us that the fast heart rate is an explosive, desperate overcompensation. The autonomic nervous system is failing to properly squeeze the blood vessels in the lower half of the body.
So the blood is just hanging out down there.
Right. Because the blood is pooling in the legs, the brain realizes it isn't getting enough oxygen. So it panics. It sends a massive surge of adrenaline to the heart, essentially screaming, pump harder, pump faster.
Mm-hmm.
The racing heart isn't the primary problem. It's the body's frantic attempt to fix the plumbing issue.
And we really have to talk about what actually causes that invisible wiring to fail in the first place, because there is a massive viral connection here.
There is a huge connection. POTS is very frequently a post-viral syndrome.
Right.
A virus enters the body, and in the crossfire of the immune system fighting it off, the delicate autonomic nerves get damaged or confused.
Which we've seen a lot of recently.
We have seen a staggering explosion of this exact mechanism over the last few years with long COVID. Millions of perfectly healthy people caught a respiratory virus, recovered from the acute illness, but were left with profound autonomic dysfunction.
Yeah. They suddenly find that simply standing up to fold the laundry sends their heart rate to 140 beats per minute.
Leaving them dizzy, breathless, and utterly exhausted.
Which is absolutely debilitating. But there is a glimmer of hope in the medical literature regarding that post-viral timeline, right?
Yes. The silver lining is that because the peripheral nerves can slowly regenerate, post-viral POTS can sometimes resolve completely on its own over 3 to 12 months.
Oh, wow.
Yeah, the nervous system eventually heals and recalibrates. But during that window, the patient needs serious management.
Okay, let's talk about that management. Because the treatments for POTS listed on this flowchart completely break your brain if you don't understand the underlying mechanics.
They seem entirely backwards.
Right. Hold on. If a patient comes in with a heart rate of 130 beats per minute, the absolute last thing I'd think to do is hand them a bag of salty chips. Isn't a high-salt diet notoriously terrible for cardiovascular health? Why is volume expansion with salt the first-line treatment?
Well, in a normal, healthy heart, yes. Excess salt is a cardinal sin because it drives up blood pressure. But remember, POTS isn't a heart disease.
It's a plumbing disease.
Exactly. Salt forces the body to retain water. More water means more blood volume. By artificially increasing the total amount of fluid in the patient's circulatory system, you are giving the heart more actual volume to pump upward.
So it makes fighting gravity infinitely easier.
Precisely.
So you're basically filling the pipes to the absolute brim so the pump doesn't have to work as hard. That makes so much sense. And the physical interventions follow the exact same logic.
Right.
Doctors prescribe medical-grade compression stockings to physically squeeze the legs and abdomen, literally forcing the pooled blood back up to the heart.
Exactly. And when lifestyle modifications aren't enough, we move to pharmacology. But again, we aren't primarily targeting the heart. We use oral fludrocortisone, which is a steroid that tells the kidneys to stubbornly hold on to even more salt and fluid.
Okay.
Or we use midodrine.
Now, the flowchart calls midodrine an alpha agonist. Can you translate that into English for us?
Sure. Think of the receptors on your blood vessels as tiny keyholes. An alpha agonist is a chemical key that fits into those specific locks and forces the blood vessels to constrict. Midodrine acts like a physical elevator for the blood. It artificially tightens the vessels in the legs, pushing the blood upward, which signals to the brain that it can finally tell the heart to slow down.
And then there's the exercise component, which sounds like absolute torture if your heart is already racing.
It can be daunting.
The guidelines mandate a recumbent exercise and conditioning regimen, meaning you have to build cardiovascular strength, but you have to do it while sitting down on a rowing machine or lying on a recumbent bike.
You have to train the heart without triggering that standing, gravity-induced adrenaline spike.
If we connect this to the bigger picture, if you step back and look at that entire treatment plan, salt, water, compression, midodrine, recumbent exercise, you see exactly why securing this specific diagnosis is paramount.
It is life or death for quality of life.
Imagine if a doctor looked at a POTS patient, ignored the postural trigger, and mistakenly believed they just had a defective heart. If a surgeon were to go in and physically alter the heart's natural pacemaker to slow it down, a procedure called sinus node modification, it would be a disaster.
Because you'd be destroying the body's only compensatory mechanism. You'd be permanently slowing down the heart, but you haven't fixed the fact that the blood is still pooling in the patient's legs.
You hit the nail on the head. The guidelines explicitly warn that treating POTS with sinus node modification will not only be completely ineffective for the racing heart, but it will exacerbate all the non-tachycardia symptoms.
The patient would pass out every time they stood up because their heart could no longer speed up to get blood to their brain.
That is terrifying. It really highlights why the detective work matters. So POTS is fundamentally a battle against gravity.
Yeah.
But what happens when gravity isn't the trigger at all? Imagine you are lying completely flat in bed, perfectly still, no stress, no exertion, and your heart is still running a marathon. That brings us to the other side of the diagnostic tree. Inappropriate sinus tachycardia, or IST.
IST is a vastly different beast.
Yeah.
If the heart rate increase is totally spontaneous at rest, or if someone just walks slowly across the room and their heart rate skyrockets out of all proportion to that mild exertion, IST is strongly suspected.
Okay.
It is a relatively uncommon condition, and medical science actually still places it within a broad, murky spectrum of ill-defined autonomic dysregulation.
And the demographics are incredibly targeted. This heavily affects women in their third or fourth decades of life, so women in their 20s and 30s.
Yes. And the most frustrating part for both the patient and the physician is that the underlying physiological mechanism behind IST remains pretty elusive.
We don't really know why it happens.
We have theories, and they essentially boil down to a broken thermostat or a physiological tug-of-war. Your sinus node is the natural pacemaker of your heart. It's the metronome setting the tempo.
Right.
It receives constant inputs from two sides of your nervous system. The sympathetic side hits the gas pedal, releasing adrenaline. The parasympathetic side hits the brakes. IST might be a fundamental imbalance between those two inputs. The gas pedal is stuck down or the brake lines are cut.
But the textbook also mentions something called altered membrane automaticity of the sinus node cells themselves, which sounds incredibly complex.
Think of the outer membrane of those heart cells, like a bouncer at a nightclub, strictly controlling the flow of electrical ions in and out of the cell. In IST, it's possible that the bouncer has simply gone rogue. The pacemaker cells are intrinsically hyperactive. They're spontaneously firing off electrical signals far too rapidly on their own, regardless of what the nervous system is telling them to do.
Just firing wildly.
Exactly. Or, in many cases, it's a combination of both, the broken thermostat and the rogue bouncer.
And we need to be clear about the symptom burden here. This isn't just a mild flutter in the chest that you can ignore. It is completely life-altering. The fatigue is profound. Patients experience relentless dizziness, syncope, which is fainting chest pain, severe headaches, and gastrointestinal upset.
It hijacks their entire existence.
It does. Pinning down the diagnosis, an absolute nightmare. The guidelines explicitly state that IST must be carefully distinguished from focal atrial tachycardia.
Right.
That's a condition where an abnormal electrical rhythm is arising from a specific patch of tissue right next to the sinus node, acting like a counterfeit metronome. But even harder than distinguishing it from other arrhythmias is the psychological overlap.
This is a massive hurdle in clinical practice. The distinction between actual inappropriate sinus tachycardia and physiologic sinus tachycardia caused by an anxiety disorder or panic attacks can be remarkably difficult.
Really?
On paper, they look identical. Both cause a resting heart rate of 120. Both cause palpitations, shortness of breath, dizziness, and chest pain. But the root causes are entirely different.
Wow.
One is a psychological stressor triggering a normal physiological response. The other is a fundamental structural misfire of the body's electrical hardware.
Which makes the treatment tightrope for IST incredibly precarious. When you look at the flowchart, it moves from IST suspected straight into a very heavy-hitting medication block. But the textbook doesn't sugarcoat it. It bluntly states that therapy is often ineffective or poorly tolerated. That has to be a devastating reality for a patient sitting in the doctor's office seeking relief.
It is deeply frustrating. Because it's an autonomic issue, standard heart medications often fail. The first line of defense is usually a careful titration of beta blockers. We try to slowly introduce drugs that shield the heart from adrenaline.
But there's a catch.
Huge catch. Beta blockers lower blood pressure and block adrenaline system-wide, which means they frequently just make the patient's existing fatigue and dizziness exponentially worse.
Oh, man.
Doctors will also try clonidine, a medication that alters nerve signals in the brain to turn down the sympathetic gas pedal. They even use serotonin reuptake inhibitors, or SSRIs.
Which we typically think of as antidepressants.
Exactly, but which have very complex, poorly understood effects on the autonomic nervous system.
But there is one specific fascinating drug mentioned in the guidelines that really stands out because its mechanism is so highly targeted. Ivabradine.
Ivabradine is a brilliant piece of pharmacological engineering. To understand why it works, we have to look really closely at how a heartbeat starts at the cellular level. There is a very specific electrical current inside the pacemaker cells of the heart called the if current. The I stands for current, and the F literally stands for funny.
Wait, scientists actually named a crucial part of our heart function the funny current.
They did. It was named by the researchers who discovered it because it behaves so strangely. Most electrical channels in a cell open when the cell is actively firing. But the funny current is unique. It opens when the cell is at rest.
Interesting.
It slowly lets a trickle of sodium ions creep into the cell until it hits a threshold, and boom, it sparks the next heartbeat. The funny current is the literal metronome of your life.
And ivabradine is a drug that specifically targets and blocks that creeping funny current.
Exactly. It slows down the spark.
Yeah.
What makes this a classic case of medical hacking is that ivabradine is actually approved in the United States, specifically for patients with chronic heart failure. But because doctors understood the cellular mechanism, they realized they could repurpose it. Unlike beta blockers, ivabradine slows down the sinus node without tanking the patient's blood pressure or causing system-wide fatigue. For many IST patients, it acts as a silver bullet.
So what does this all mean for the patient if they are one of the unlucky ones? The beta blockers fail. The clonidine fails. The ivabradine doesn't work. We reach the absolute bottom of the flowchart. The final lonely box on the page. It simply says, consider catheter ablation.
And the word consider in medical literature carries a tremendous amount of weight. Catheter ablation of the sinus node is the ultimate nuclear last resort.
Right.
The procedure involves threading a wire catheter up through a vein in the groin all the way into the heart. The electrophysiologist maps the exact source of the rapid electrical signals and then intentionally burns or freezes the tissue of the sinus node to physically destroy parts of it.
Wow.
You are intentionally permanently damaging the heart's natural pacemaker to force it to slow down.
The stakes there are astronomical, and the guidelines are remarkably pessimistic about it. The text warns that long-term control of symptoms is usually poor. But worse than the procedure failing to help are the risks of the pendulum swinging too far in the opposite direction.
It is a profound trade-off. By intentionally burning the sinus node, you run a very high risk of leaving the patient with a permanent pacemaker requirement.
Because it's too slow now.
Right, you can cause symptomatic sinus bradycardia, where the heart rate is now dangerously, painfully slow. You can cause sinus arrest, where the natural pacemaker temporarily just gives up and stops firing altogether. And perhaps most devastatingly for a young active person, you can cause chronotropic incompetence.
Meaning the heart loses its ability to speed up at all.
Precisely. Because the tissue that normally hits the gas pedal has been burned away. The patient might be cured of their resting tachycardia, but they are now physically disabled in a completely different way. It is a terrifying prospect, which is why the flowchart places it at the absolute end of the line.
Stepping back and looking at this entire deep dive, it is truly mind-blowing how a single, seemingly simple symptom, a racing heart, opens up this massive, complex labyrinth of autonomic dysregulation.
It really does.
Everything we've unpacked today, from the respiraphasic vagal tone to the baroreceptor reflex to the autonomic devastation of viral infections, demonstrates that the sinus node is perhaps the single most sensitive, exquisitely tuned receiver of environmental and physiological data in the entire body. Until next time, keep exploring.